He's very good. Let's Dr. Philip Ovadia to the stage. Is he there?
Hey, gents, how we doing?
Yes, very well, Philip. How are you?
It's good to be back with you guys.
12 months came and went.
Time always flies, but we're all getting younger, right?
Absolutely. So you're actually driving right now?
I am. Had some travel snafus, so I'll be doing the drive with you.
Fantastic.
The interesting live stream driving.
Yeah, absolutely. Right, for people that don't know you, if you could give yourself a little introduction, that would be most appreciated.
Sure thing. So my background is as a heart surgeon, cardiac surgeon, for over 20 years now. And for much of that time, I was a very unhealthy heart surgeon. I had reached a point that I was morbidly obese, pre-diabetic, and realized that I was going to end up on my own operating table, so to speak. And I, like so many of my patients, was kind of at a loss because I was following the advice that I had been taught, eat less, move more, eat a low-fat diet. And it wasn't working for me. It wasn't working for my patients. And I started seeking out different information and ultimately first came across kind of low-carb ketogenic approach. Lost over 100 pounds and reversed my pre-diabetes. And that ultimately evolved to a carnivore approach, which I've now surpassed 5 years on, a primarily carnivore approach. And I now help people to stay off my operating table. While I continue to work as a heart surgeon, I'm increasingly focused and have a telemedicine practice to help people stay off the operating table. Written a book by that title, Stay Off My Operating Table, host a podcast, and have become a big advocate for low-carb carnivore approaches as our way to optimize not only heart health, but overall health.
That's very full and also concise, potted history there, Philip. That's fantastic. One of the questions we had earlier, I'm going to throw straight at you if you don't mind, because it stuck in my mind, which was the coronary artery calcium scan that somebody had, which was 1,114, and
Yep.
Obviously they were concerned about that. So two-part question really. One is, what's the value, in your opinion, of the CAC? Does it have a place in healthcare, and what is that place? And secondly, what can that person do to potentially reverse that?
Yeah, so I think the coronary artery calcium scan is an essential test for anyone that is interested in their heart health. It is our early warning test. I liken it to a mammogram for breast cancer. We can detect heart disease at its early stages, and once we detect it, we can then do something about it. The unfortunate reality around heart disease is the vast majority of people first discover that they have heart disease when they have a heart attack or a serious event around their heart health, and we should do better than that. The traditional approach to prevention and, let's say, early management of heart disease has centered around blood testing, lipids, cholesterol levels in particular. And quite frankly, that approach is ineffective. It's disappointing. It really doesn't help people to prevent heart disease, and heart disease is largely preventable. So, the statistics around heart disease, it's the most common killer. It's the most common cause of death worldwide, in the U.S., in all Western nations. And the reality is that heart disease is largely preventable. And oftentimes we're discovering it too late. So I'm a big advocate for the coronary artery calcium scan. I think men around the age of 40, women probably around the age of 50, and maybe you want to do it earlier than that if you have strong reason to be concerned, like a family history, like you know that you're in poor metabolic health or were in poor metabolic health. If you've been a smoker, any of these things, then you may want to get the test earlier. Now, once we figure out that you have evidence of heart disease on a coronary artery calcium scan, then you have to, manage it. And the best way to slow down the progression of coronary artery disease, of atherosclerosis, of this plaque that we're concerned about, is with a metabolic health centered approach. So identifying and reversing insulin resistance is really at the top of my list. And obviously the spectrum of insulin resistance can include things like diabetes, type 2 diabetes. And so you want to address those first and foremost. There are some other things that come into play, some other lifestyle factors that deal with metabolic health, but also have other effects. Anything ultimately that causes inflammation in the body has the potential for leading to worsening disease in the arteries. So you want to address things like that as well, autoimmune disease, for instance. And those are kind of the basics of how we stop the progression. Now, whether or not you can reverse it is somewhat controversial. In the patients that I've worked with, we do see some lower of coronary calcium scores, maybe on the order of 10 or 15%. Someone with a score of 1,000 probably is not going to go to zero. Maybe you can lower it a little bit to 800, 900. But really what we know is if you're not at a place today where that disease is truly significant, that you might need a stent or bypass surgery, as long as we stop it from getting worse, as long as we keep that coronary calcium score from getting worse, that should put you in a good place to be at a low risk of a heart attack in the future.
Excellent. Yeah, we've got a few people sharing their scores. Karen Miles, who's watching, she's 369. Mine was 639. So it's quite odd there. And I remember when I got mine, just giving people some context here, my consultant actually said, look, the guy before, it was 3,000. So the numbers seem to be frightening wherever you go. So like Karen was worried. She had the 369 score because they said, well, 400 is really bad and 369 is very close to 400. But it's a long way off 3,000, isn't it? So is it simply a number that really actually is not that important compared to all other health markers? Or if you've got one of 3,000, is the number up, basically? You're going to be dead within 5 minutes.
Well, yeah. So none of these high scores are that predictive. They don't really tell us, are you at imminent risk for a heart attack? They sort of reflect accumulated damage. And the question one needs to ask as the score gets higher is, how bad is the disease that I have? Because there's a limitation of the calcium score. It's only showing us the calcified plaque. It doesn't show us the non-calcified plaque that can go along with this. And it doesn't really tell us how narrowed a blood vessel might be. I've seen people with scores as low as 200 to 300 that end up having a significant blockage that we need to do something about. And I've seen people with scores in the 2000s that don't end up having a significant blockage. And you can kind of picture If all of this calcium is in one area of one blood vessel, a 200 score might be enough for that to be a significant blockage. If you have 2,000 score, but it's all spread throughout the blood vessels kind of evenly, then you may not have one particular area that, is significantly blocked. So it's just a screening test. I tell people it's not the definitive test. If your score is 0, we know you're at low risk of having any sort of significant disease. If your score is high, and I usually use about 400 as the cutoff, but a lot of it depends on the nuance. Like I said, there are people with scores of 200, but all that calcium is in one area, and I'm a little concerned about that. And then we have to do the further testing to determine, do you have significant blockages? And this is where we might get into things like CT angiograms, which are a more involved test, or even a cardiac catheterization, where we're actually doing an invasive test to determine how blocked the blood vessels actually are.
Yeah, and I think I'd like to just broaden this question out a little bit anyway and talk about other markers that are used, which could also be misleading. So I'm going to ask you the sort of $1 million question is why do you think that high LDL cholesterol is still by many considered to be the gold standard for indicating whether you're going to have a heart attack or not, when there doesn't seem to be enough evidence to be that confident?
Yeah, quite frankly, it's the gold standard because we have pharmaceuticals that can lower your LDL level. And that has been the traditional approach, is that, LDL is the most important marker. And if you lower LDL, whether through diet or pharmaceutical approaches, that's going to lower your risk of developing heart disease. And the problem is that approach isn't working very well. We've been using this LDL-centric approach now for over 40 years that we've had the pharmaceuticals. And really, you can go back 70 years when we started the dietary approach to lowering cholesterol, lowering LDL. And here we are, heart disease is still far and away the number one killer. And the reality is that half of the patients who end up on my operating table, half of the patients who come into a hospital with heart attacks do not have elevated LDL cholesterol levels. And so it's clear that LDL isn't the entire story. Is it part of the story? Yes, it is. But it's not the most important part of the story. And this is where we go back to insulin resistance, which in every study that has ever compared the two, insulin resistance is a much bigger risk factor for heart disease than LDL cholesterol is. So, when I'm talking with my colleagues, and understand that most physicians haven't heard the contradictory information around LDL cholesterol. They really only get to hear the information that supports the LDL hypothesis. And, there's many reasons why that is that maybe we don't want to get into. Maybe we do. But, taking it for what it's worth, what I talk to my colleagues about is, okay, LDL may be a factor, but there's a much bigger factor that we know, and that's insulin resistance. So let's talk about that. Let's address that. And the unfortunate reality is that insulin resistance isn't as easy as just writing a prescription for a medication that lowers your LDL cholesterol.
Yeah. Basically, they haven't got a solution that they can sell you. So we're sticking with one where they can make a profit. I totally get that. It's very sad for for patient outcomes and also for their confidence in what's going on, because I'm seeing a big sea change in people now. Before, they'll send me bloods and they'll actually say my LDL is really high, but I'm not worried about that, little bracket, haha. So I think the word's getting out there amongst the general population that there are better markers, or that LDL is a sort of flawed metric to be used. So thanks for clearing that up, Philip. That's really appreciated. We've got quite a nuanced question that someone has put through, so I'll just ask you that, and then we'll go back to maybe a more broad question. But this one is just saying, Dr. O, please, why don't many cardiologists do the Watchman procedure to the heart?
So the Watchman procedure is for a particular heart condition called atrial fibrillation. So this is an irregular heartbeat that people develop, and it has become somewhat common. It's more common the older people get. There are some other risk factors that go into it. And the concern around atrial fibrillation is because the heart, basically the chambers of the heart are not beating in a coordinated manner, the blood can start to pool, and it starts to pool in a particular area of the heart that we call the left atrial appendage. And, the analogy to this is sort of like the appendix of the colon. It's kind of a little outpouching, and it's a little pocket where blood clots can start to form. And if blood clots form in there and then they get pushed out of the heart, this can lead to a stroke, which is a risk factor, for people with atrial fibrillation. They're at increased risk of developing a stroke. The Watchman procedure, so the usual approach to that is you put people with atrial fibrillation on blood thinners that will prevent the blood clots from forming. What the Watchman procedure does is it goes and basically mechanically blocks off that appendage so that the blood is no longer in that area and can't pool and form blood clots. It's an invasive procedure. It's a highly specialized procedure. You need a physician that has undergone proper training to do this. And, we're still figuring out, it's a newer procedure. We're still figuring out where it fits in that algorithm as to should someone just take blood thinners or should they have this procedure done? Are there things that we can do to get people out of atrial fibrillation, which in this context is an interesting discussion because inflammation seems to contribute to atrial fibrillation. And if perhaps you go on an anti-inflammatory diet like a carnivore diet, can that help with atrial fibrillation? Again, I have some patients in my practice that have atrial fibrillation and have seen improvements in their atrial fibrillation when they go on a carnivore diet, when they lower their inflammation, when they address insulin resistance. So, for the person that asked the question, the Watchman procedure is an option. I wouldn't say it's an end all and be all. People who have the Watchman procedure done may be at lower risk of a stroke, but they're still in atrial fibrillation oftentimes. So it's something to consider if you have atrial fibrillation.
You're doing brilliant, Philip. Thank you so much. That's brought another question out from a different person. Can aspirin be enough to thin blood?
It depends what context you're talking about. For something like atrial fibrillation, no, it's not enough of a blood thinner. When we're talking about, people with atherosclerosis, with plaque in their arteries, that we're trying to lower their risk of a heart attack, it may be enough. Honestly, I am not a huge fan of aspirin in and of itself. For my patients that have that we know have coronary artery disease, have atherosclerosis, I'll oftentimes recommend a supplement called nattokinase, which is a kind of natural blood thinner. sometimes in combination with aspirin. So aspirin is a blood thinner, but it's kind of a weak blood thinner, and depending on the context, it may not be enough.
Excellent. Excellent answer. Dr. O, I know this might sound weird, but can forced coughing jolt the heart out of an arrhythmia?
Yes, actually it can. There are certain types of arrhythmias that, a quick sort of jolt, whether it can come from something like coughing or there's a maneuver where you can actually, and I don't suggest people just try this at home on their own, but in the clinical setting, a kind of thump to the chest can get people out of arrhythmias sometimes. So yes, a cough can sometimes do it. But if you're having an arrhythmia, it's probably something you want to see a doctor about. And if it's occurring on a repeated basis, it's something you want to see a doctor about, certainly.
Yeah, and I think that's a handy thing for me to just remind everybody, none of this is medical advice. It's information and entertainment, not a doctor-patient relationship. One of the questions I remember from earlier, which I just off the top of my head, somebody was asking, and we asked one of the guests, one of the other doctors, but you're probably a better person to ask. They have left ventricle injection fraction of 25%, and they're a male of 51, and they was wondering if the carnivore diet might be able to improve those figures.
Yeah, so basically what those numbers are saying is that they have low heart function, and this can come from a number of different reasons. It can result from heart attack. It can result from viral infections. There can be a number of causes of low heart function. But can a carnivore diet help that? I would say certainly it can. Now, the research that we have is more around ketogenic diets more broadly. And of course, carnivore diets usually are going to be ketogenic because they are low carbohydrate, but they may not be, let's say, a high ketogenic diet. You might need if you're trying to get into a truly ketogenic diet with a carnivore approach, you might need to look at a higher fat, kind of lower protein carnivore style diet, which certainly can be done. Ketogenic diets have shown benefits in heart failure. So people with low heart function, most of that data, I admit, is animal data, but we do have some, small human studies that suggest that the heart in heart failure prefers ketones as its energy source to glucose. So providing more ketones with a ketogenic diet approach certainly can have benefits. And again, the patients that I've worked with, we have seen improvements in how they feel. We have seen improvements in their ejection fraction in patients that, try this. I'm fairly confident in saying that it's not going to hurt things. Again, there is nothing about eating meat that is damaging to the heart. And that is very contradictory to what most people hear from their physicians, but it's what the evidence shows us, what the science shows us, and, what the now collective experience of the large carnivore community demonstrates to us as well.
So why do you think some doctors still recommend avoiding saturated fat if you want a healthy heart?
Well, quite frankly, because they've been brainwashed into that. And again, that's what they've been taught, and they haven't seen the evidence to the contrary. But the evidence to the contrary at this point is quite robust. There was a large, review, meta-analysis of this topic, now published 3 or 4 years ago in the Annals of Internal Medicine. And they showed that the link between red meat consumption and cardiovascular disease really is not supported by the scientific literature. And likewise, the link between saturated fat and heart disease has also been thoroughly disproven in the overall analysis of the scientific literature around this. So they're just working with outdated information, and they just haven't seen the contrary information because it just doesn't get promoted. Because again, it goes against this cholesterol-based narrative around heart disease.
So if you were recommending some labs or some tests to get to indicate heart health or how good or how bad it is there any markers that you feel are reliable to look at?
Well, like I said, insulin resistance is a major risk factor for heart disease. And so you want to know, are you insulin resistant or not? The best way to test that is going to be get a fasting insulin level, and then get my preferred test is what's called an LPIR score. So lipoprotein insulin resistance score. This is a score that's based off of what's called an advanced lipid panel or an NMR panel. It's a panel that's going to look at the size of your cholesterol particles, and we can use that to determine how insulin resistant you are. And that, like I said, is a key piece of information when it comes to heart health. Now, if you can't get that testing done, and I know sometimes it's not available to people, you can look at the ratio between your triglycerides and your HDL cholesterol. Importantly, this ratio needs to be determined in the US units, milligrams per deciliter. So I know you have audience worldwide. Certainly you have a lot of audience in the UK. You have to convert from the millimoles to the milligram per deciliter. And there are lots of calculators online that you can do that. And then do the ratio. And if that ratio, your triglyceride level divided by your HDL cholesterol level, is less than 1.5, you can be fairly confident that you're not insulin resistant. It's not as good as getting the LPIR score, but it can be an indicator for people that don't have access to that testing. So insulin resistance is one thing you want to test for. And then inflammation is the other thing you want to test for. And this can be something like a what we call CRP, C-reactive protein level is the most common inflammation test. But if you don't have inflammation and you don't have insulin resistance, those are going to be relatively good indicators that you're at low risk for heart disease. But I would still go ahead and get that coronary artery calcium scan and make sure that you don't have evidence of heart disease.
That is brilliant. Richard's been quiet. I think he's stunned into silence. But Richard, you must have a couple of questions.
Hey, I'm happy just to be listening to Philip. I've just been stuffing my face while you guys have been. So this is the first time that I've eaten since not last night, the night before, wasn't it? Because how long have we been live for now, Steve? Where are we? Just over 20 hours?
Yeah, we've done 20 hours. So
17 minutes.
Yeah, we've been live for 20 hours and 20 minutes, pretty much.
Yeah. So apologies while you two guys were conversing. I've been stuffing my face with some beef and lamb, which you'll be pleased to hear. So
certainly heart healthy beef and lamb, and compliments to you guys for doing this and being 20 hours into it and still going strong.
Yeah, I think we've had several weak moments, I'll be honest, but it seems to come in waves, doesn't it? But Just circling back to one of the things that you mentioned in regards to ketones, and the difference between being in a deep state of ketosis compared to being carnivore. And I agree, as you rightly say, carnivore is a subsection of subset even of a ketogenic lifestyle. So we are in a ketogenic state, but then ketones may be less, possibly when we're in a carnivore state. But that production of beta hydroxybutyrate has been shown to increase the mechanical efficiency of the heart. And you may know these figures a little bit better, but by memory, I'm sure it's around 35%, which is pretty substantial.
Yeah, I mean, again, it depends kind of what context you're looking at. If you have normal heart function to start with, I'm not sure that ketones are really going to, augment that beyond kind of the normal level. But if you have a reduced heart function to start with, we certainly can see improvements with ketones. Ketones do seem to be the preferential fuel for the heart. And, it's interesting that the heart actually has a way of sort of getting to the ketones, to the fat first. There's a drainage system, it's called the thoracic duct, that goes straight from the intestines to the heart. And it kind of bypasses, the liver and all the normal pathways. So that gives us some evidence that, the heart is looking for fat to use for fuel. And, the level of ketosis, I don't think is important in all contexts. People that come to me that are just looking to generally improve their health, and, I think a carnivore diet with sort of low-level ketosis is going to be just fine for. I think there are certain contexts, certain conditions that high level of ketones are going to be beneficial. Heart failure being one of them, some of the neurologic and psychiatric conditions being the other. And those are when I oftentimes am working with people to kind of tweak a carnivore approach. And like I said, make it a more high fat, lower protein, still carnivore diet that can help to promote that higher level of ketosis. Of course, fasting is another thing that can help to promote higher levels of ketosis. So these are all things that we can play around with depending on the patient that's in front of me, who I'm working with, and what we're trying to accomplish.
Yeah, we got a question here from Jill. She's saying that she had Bigemini for many years. Now that I've been carnivore, it's gone. Have you seen this happen before?
Yeah, like I said, I've seen many contexts. Bigemini is another type of arrhythmia that we were mentioning about earlier, kind of an irregular heartbeat. This has to do with the electrical system of the heart, and inflammation within that electrical system seems to be at the root of many of these arrhythmias. And so I have seen things like that improve with low inflammation that comes with a carnivore diet.
Okay. What's your views on things like Nick Norwitz's Oreo cookies YouTube?
Yeah, I think it was a very interesting demonstration of, how LDL may not tell us the whole story. Because, obviously, eating Oreo cookies in large amounts like Nick did for that experiment, no one would say is healthy, and yet it lowered his LDL cholesterol. So I think it exposes how LDL doesn't tell the whole story. And, I want people to understand that I don't think that LDL is completely meaningless. I don't think that if you have a high LDL, that necessarily should be ignored It's just that you need to understand the context of that high LDL. Because if you have a high LDL with insulin resistance, with inflammation, it is certainly problematic. Now, lowering the LDL in that context, and this is unfortunately oftentimes what I see, in medicine, is someone will obviously be insulin resistant. They may be type 2 diabetic, and they have an increased LDL, and their doctors will dutifully treat elevated LDL, but they won't do anything about the insulin resistance. And that person is still going to be at significant risk for heart disease. And again, we see this all the time. Very common scenario that a patient like that ends up on my operating table. Whereas we have other people, and of course, we're seeing this commonly in the context of low-carb diets, carnivore diets, that their LDL is very high, but they don't have insulin resistance and they don't have inflammation, and they don't appear to be, having significant heart disease. And of course, we're still gathering data on this. The lean mass hyperresponder study, which we hopefully will be getting results from, later this year, will give us some more context around this. We already got some preliminary results from that study that give us more context around this. And so that is where, again, I emphasize to people that the basic cholesterol panel, just seeing your LDL number, is not enough. It doesn't tell us the context. We want to see things like particle sizes. We want to know if you're insulin resistant, if you have inflammation, to determine, do we need to be concerned about a high LDL or not?
Cool. We've got a question here, Dr. Avadia. Do you think carnivore would help vascular edema in the legs to eventually wean off of diuretics? Thank you for your wisdom. I just started reading your book.
Yeah, well, thank you for that. And yes, I do think it can help with vascular edema, swelling of the legs. Now, of course, you want to figure out, why do you have swelling of the legs? Is it because your heart isn't working properly? Maybe it's because your ejection fraction is low and you have heart failure. Maybe it's because of inflammation in the veins of the legs that has damaged the what we call the valves that are supposed to prevent kind of backflow of fluid into the legs. Maybe it's because of problem with the lymphatic system, which is sort of the other drainage system of our legs and of our body. All of these things, though, usually are going to be improved by lowering inflammation, lowering insulin resistance, like I said, getting into ketosis, eliminating a lot of the things that a carnivore diet eliminates: ultra-processed foods, excess sugar. These are all the reasons that I would be quite confident that a carnivore diet can help with that. And I'm also quite confident in saying it's not going to hurt it in any way. So it's worth a try.
Fabulous. Richard.
Yeah, I was just curious in regards to lipoprotein little a. Could you explain that to us in a little bit of detail, please, Philip?
Yeah, great topic, great thing for us to touch upon, because lipoprotein A is another under-recognized risk factor when it comes to heart disease. So lipoprotein A is a type of LDL cholesterol particle. Lipoprotein A has an extra protein on it. That's what the lipoprotein A is. And that extra protein basically allows or causes this particle to interact with the blood clotting system. People that have elevated levels of lipoprotein A are at increased risk of blood clotting, and that is one of the factors that contributes to plaque formation. For anyone that's not familiar with the role that blood clotting plays in the heart disease process, I recommend to start with Dr. Malcolm Kendrick's book, The Clot Thickens. Dr. Kendrick does an excellent job of explaining how blood clotting is part of the atherosclerosis, the plaque formation. Lipoprotein A predisposes people to that. And so it's another important test to check. It is largely genetically determined, although there does seem to be some influence of dietary factors to this. And we sometimes see people who have elevated lipoprotein A levels that can improve again when they go on low carbohydrate carnivore type diets. If your lipoprotein A level isn't elevated, then, you really don't have to worry about it. And if it is elevated, a key thing to understand is that lipoprotein A, in the context of inflammation, has been shown to be particularly harmful. So there was a study released a couple of years ago that looked at people with elevated lipoprotein A levels, and they looked at whether or not their C-reactive protein level was elevated, which, as I said earlier, is a measure of inflammation. And what they found is that in people with elevated Lp(a) levels, lipoprotein A levels, that had normal CRP levels, so they didn't have inflammation, there didn't really seem to be any significant increase in their risk of heart disease. It was only in people that had elevated inflammation markers combined with Lp(a). So for my patients with elevated Lp(a), I emphasize even more strongly, we have to avoid inflammation in order to lower the risk associated with that Lp(a).
Okay, so I mean, the general trend, I think, Philip, is that inflammation is a massive contributing factor to this. Then there's no one definitive measurement that is going to give us an answer in regards to whether we are high risk or not. There seems to be several factors which are almost cross-referenced. I'm guessing. Is that fair to say?
Yeah, I think it's very fair to say that heart disease ultimately is multifactorial. So, and again, this circles back to the fallacy of LDL cholesterol. To think that we could reduce heart disease to one number is really just foolhardy. It's not that simple. It is multifactorial. There are lots of things we need to look at. Inflammation, insulin resistance, those are two of the big ones. And the bottom line for me is when we address those things, it usually takes care of really all the other things that go into heart disease. Now, there may be some exceptions to that. And again, you have to pay attention. For instance, if someone is a smoker, that's another obvious risk factor that you want to eliminate. But ultimately, insulin resistance, inflammation, these are two of the biggest risk factors, and these are both addressed by low-carb carnivore diets. And that's why I think these diets are so powerful in combating heart disease.
Yeah, fantastic. I mean, just coming back to LPA, I mean, what's the correlation in regards to that with LDL? I mean, are they both elevated together? Are they opposites? Is there a correlation between the two?
Not necessarily. So one can be independent of the other. You can have people with low LDL levels that have elevated lipoprotein A levels. You can see the reverse as well, elevated lipoprotein A, but low LDL. And one of the interesting things about the pharmaceuticals, statins do not affect Lp(a) levels really at all. The data on statins and LP(a) actually show, some of the studies show things in both directions, that it increases LP(a) or it just doesn't affect LP(a). The more powerful cholesterol lowering medications, what we call PCSK9 inhibitors, they very dramatically lower LDL levels, but they seem to have minor effects on LP(a), maybe lower it 10 to 15%, but nowhere near as dramatically as they lower LP(a). As they lower LDL. There are some pharmaceuticals being developed that specifically target lipoprotein A. These medications are still in trial, and we really don't know if they're going to be effective in lowering heart disease ultimately. So to be determined. And like I said, we really don't have a whole lot of tools available to us to reliably lower LP(a) levels. So that's why for people with elevated LP(a), my biggest piece of advice is avoid the inflammation that we know is so dangerous in combination with it.
Yeah, fantastic. One of the other things that I wanted to ask was, we're told that consuming saturated fats or excess fat consumption can raise cholesterol. Now, we know that that's not a problem unless we're in a state of insulin resistance and inflammation. But several people within the community I've spoken with say that there's no known mechanism in which we can increase cholesterol through dietary means. But I can't understand the thought process behind that. And the reason for it is, if we are living a ketogenic lifestyle, then we use the shared pathway HMG-CoA to create ketones, and the mevalonate pathway for cholesterol. Is it at least possible that we can influence our cholesterol levels through being ketogenic and consuming the fats? Not that it's a bad thing, but is there a possible mechanism in which that can happen? We know that we can increase desmosterol through living a ketogenic lifestyle. So being the precursor to cholesterol, it makes sense that we're able to do that. But a few within the space that I've spoken with seem to say that there is no known mechanism for which dietary fat can increase. But the shared pathway, the fact that we share the mevalonate pathway, seems to make sense that it could be possible in which we're producing X amount of ketones and there could potentially be an overspill.
Yeah, I think ultimately this is sort of the context of, the lipid energy model that Dave Feldman and others have promoted. And that, it may not be a direct dietary conversion. So it's not that the saturated fat that you're eating is being directly converted to cholesterol that's causing the elevated cholesterol levels that we see in some people that go on low carbohydrate diets. It's more that you're setting up this metabolic environment that your body needs increased trafficking of fats to support your metabolism, your ketogenic metabolism, and therefore the cholesterol, the LDL cholesterol level goes up. We know that the influence of our dietary fat on our blood cholesterol levels is pretty small, maybe on the 5 to maybe 10% range. And it's more, I think, the metabolic context that you're creating in your body by what you're eating that's ultimately going to influence your blood cholesterol levels. Yeah. The sort of lean mass hyperresponse is very variable. Some people that go on low carbohydrate diets see it, but it seems to be a small percentage. The overall data that we have when we look at large studies of people on low carbohydrate diets is that the cholesterol level really doesn't change on average. Some people it goes down, some people it goes up, and some people it doesn't really change at all. The changes that we see sometimes can be temporary. So I oftentimes see people, initially when they go on a low carb diet, and if they're losing a lot of weight, their LDL, their cholesterol levels may go up, and then they kind of settle back down with time as they weight stabilize. And then, of course, there is the subset of people that get this lean mass hyper response, and their levels go up dramatically and they stay up dramatically. And we're figuring out what all of that means. But, again, I think the takeaway we have now is that it may not be the same thing as someone that has a elevated LDL cholesterol level in the context of inflammation and insulin resistance.
Yeah, fantastic. And I think, many who gravitate into a ketogenic or carnivore-based lifestyle see an elevation in cholesterol overall. And I think, is it safe to say that this is a case of removing the phytosterols and basically just having our cholesterol return back to a natural physiological level in which those phytosterols have artificially lowered it previously?
Yes, I think there is a lot of validity to that theory. Again, it's not something that's been rigorously tested in the scientific literature, but we do know that these phytosterols, because they are basically a competitor for the same receptors, will lower LDL levels. This as will the polyunsaturated fatty acids, in the vegetable and seed oils. Again, I don't argue that vegetable and seed oils lower your LDL cholesterol. I don't think that's arguable. That's fairly consistent. Whether or not that's good for you ultimately is where we have disagreement with the mainstream concept that lowering your LDL is always better. And again, we alluded to Nick Norowitz's Oreo experiment earlier, that you lowered your LDL in that context. Does that mean that it's a good thing? This is what we're starting to unravel and hopefully understand better.
Yeah, fantastic. One other thing from me, Philip, if you don't mind, is could you explain a little bit more about the lean mass hyperresponder? Is that, I know you just touched base on it, is it something to be concerned about? What's the mechanism involved? And, is it something that we should be worried about? Because I guess it would be for a person who is uneducated, even a person who is educated maybe about cholesterol and the fact that cholesterol is essential for life and high LDL isn't a problem. I mean, to see an increase, such a rapid increase, would that, or is it a concern to somebody?
Yeah, I mean, I think we're starting to understand that this is a unique metabolic state that we haven't really seen before. And it seems to be, again, mostly lean people, although we do see some people that are not actually all that lean that have a similar response. And I think it basically, and again, I of course give full credit to Dave Feldman, who has helped to stimulate this discussion, and of course is now doing some very important scientific work to help us better understand this. But I think the lipid energy model that he has proposed makes a lot of sense. That basically, people are putting themselves into a metabolic state that is demanding more trafficking of fats for energy, and therefore we're seeing it as, increased blood cholesterol levels as these fats are being trafficked. Is it something we should be concerned about? What I tell people at this point is it's something that you should be concerned about, but it doesn't mean you need to change it. And I think careful observation for now is a very prudent approach. That careful observation should probably include things like serial imaging with CAC scans, maybe even CT angiograms, to make sure that your heart disease, that you're not developing or rapidly progressing heart disease. The study that's being, currently done, again, is going to give us some more information around this on a population level. But I always tell individuals in this situation that, it's an individual response. And so therefore, I think it does warrant careful observation, but that doesn't mean that you necessarily need to change it. The other thing to understand is a lot of people have rightfully pointed out that, you can modulate it fairly easily. You can introduce a little bit of carbohydrate back into the diet, and that in many people will significantly lower their LDL cholesterol level. Now, again, does that mean that we're changing their outcomes in any way? We have no evidence of that, because if we're saying you're probably not at risk from this high LDL to start with, then lowering the LDL shouldn't really make any difference, but it is an option. It's also an option to use pharmaceuticals to lower your LDL in this context. And I do know that there are some lean mass hyperresponders that have gone that route. But again, I put forward that you may not be changing your risk any just because you're changing one number on your blood panel. And, that may be the bigger lesson in all of this, that, hyper-focusing on one number on your blood panel may not be the right approach. And that's kind of been my biggest takeaway from all of this. As a physician, the sort of challenge to the dogma that the lean mass hyperresponder, presents is really what's most interesting to me, because, if we can expose something as dogmatic as LDL, what else are we wrong about? And that's what I think about more as a physician. And I think it's incumbent on us as physicians to always be thinking about what we might be wrong about.
This is great. We've got a final question. So thank you for doing 45 minutes while you're driving. Do you attribute the increase in cardiac disease to a correlation with seed oil intake?
Yeah, I think there is a lot of evidence to correlate those two. Now, more broadly, it's pretty clear that ultra-processed food is contributing to this increase in heart disease. And, what component of the ultra-processed food is it? Is it the seed oils? Is it the sugar? Is it the other, kind of highly refined carbohydrates? It really becomes difficult to separate those out. But, again, when we look at this on a kind of ancestral level, the reality is that sugar is something that we have been exposed to for very, very long periods of time, whereas seed oils are not something that we have been exposed to for long periods of time. So I am very suspicious and cautious about seed oils. They're certainly not essential to human life, and I really don't see much reason to consume them. And I think, again, that's one of the things that's most powerful about a carnivore diet is, you're pretty reliably eliminating your exposure to seed oils with a carnivore diet. Whereas with a, low-carb diet, a ketogenic diet, you may not be eliminating seed oils. A lot of, low-carb ketogenic products can still have a bunch of seed oils in them. And that is concerning to me. I think mechanistically, seed oils are more concerning to me than sugar might be, natural sugars. And of course, consuming sugar in excess is going to be problematic. But, there was a large period of time where I would say human beings were consuming sugar without seed oils, and we didn't really seem to see this dramatic increase in heart disease until the seed oils were introduced. And ultimately, they may work together. The way that I think about it is seed oils may end up breaking our metabolic machinery. And once our metabolic machinery is broken, we can no longer tolerate sugar and carbohydrates. So I think they work somewhat synergistically.
Brilliant. Dr. Philip Avadia, that's so good. Did you want to plug your book or any of your services before you go?
Yeah, sure thing. The book, as I mentioned, is called Stay Off My Operating Table, widely available, all the usual places. And then if anyone wants to connect with me, I'm at iFixHearts all over social media. And then you can go to ifixhearts.com. As I mentioned, I have a telemedicine practice that I see patients. I'm still actively practicing medicine, delivering full medical care via telemedicine all throughout the U.S. and even internationally. And if anyone is interested in that, you can go to ifixhearts.com and find out more about the services that we offer.